Honorable Emeritus Chairperson, distinguished faculty members, teachers, and all my dear colleagues, good morning to one and all. I, Dr. Prashansa, on the behalf of the Department of Oral and Maxillofacial Surgery, will commence today's CCR. To begin with a brief outlook of our department, oral and maxillofacial surgery is a surgical specialty which focuses on reconstructive surgery of face, facial trauma, head and neck surgery, surgery of mouth and jaws, facial plastic as well as cosmetic surgery, and surgeries of cleft lip and palate. We are a team of 8 faculty members and 15 postgraduate students. Initially in the year 2010, our specialty had 2 MDS seats, which increased up to 5 seats from the year 2015. Till date, about 40 postgraduate residents have been successfully passed from our department and are doing well in country as well as abroad. The department has seen massive growth in the number of cases operated over the years, as in the year 2023, our department had operated about 600 minor and 280 major cases. The department deals with various pathologies of cysts, TMJ disorders, and neuropathy, but it has a major hold on trauma and resective and reconstructive surgery over the years. The dental surgery comprises about the minor surgery, which deals with simple to surgical extraction, advanced dental implants in the form of zygomatic implant or orbital implant, bone grafting procedures, and alveoloplasty, whereas the maxillofacial surgery includes the major surgeries which deal with benign and malignant pathologies like cyst and jaws of tumors, congenital malformation in the form of cleft lip and palate, trauma of oral facial region, and temporomandibular joint disorders. It also involves reconstructive surgeries which require reconstruction in the form of iliac bone graft, free fibula graft, and cancellous bone graft, as well as soft tissue reconstruction in the form of various flaps like submental, subplatysmal, temporalis, including dermal flat grafts, fascia lata, and PMMC flap. Aesthetic surgeries like hair rejuvenation, scalp micropigmentation, and saddle nose correction are also being carried out in our department. Department has been enthusiastic enough in carrying various scientific activities in the form of CME in head and neck cancer, various workshops which include the placement of zygomatic implants as well as TMJ arthrosynthesis, workshop on microvascular reconstruction which hands-on chicken leg piece was carried out in our department in last year. Last year, on 13th of February, we celebrated OMFS Day by creating social awareness regarding road traffic accident in the form of walkathon. Our department has been privileged enough in the form of our HOD sir, who has been the master of many first surgeries that has been carried out in India. To list a few, endoscopic surgery for optic nerve decompression in the orbital fluid, transantral orbital fluid reconstruction, endoscopic assisted reduction of the subcondylar fracture. He has also been awarded with the Award of Excellence in the year 2022. It gives me immense pride to say that our department is the only microvascular surgery unit that is operating from our fraternity in the state of Rajasthan. As faculty member, Dr. Ruchika Tiwari ma'am has been awarded with the Fellowship in Head and Neck Oncology in the year 2021. Along with this, our department has published more than 20 articles in the last 2 years, and all of the residents, like various of the residents, have secured Best Poster and Presentation Awards in the various national and international conferences. With this brief overview of our department, let's move to today's CCR, and we present to you a case of 25-year-old female with swelling in the tongue, who presented in our OPD with a chief complaint of pain, swelling, and bluish discoloration in anterior part of the tongue and floor of the mouth since 9 months. Patient was fine 9 months back, then she experienced dull, intermittent pain with respect to the anterior tongue, which was associated with swelling and bluish discoloration that increased from a peanut size initially up to the present size. The patient took over-the-counter medication, which were analgesic, which caused relief in the pain. There were no aggravating factors associated with it. There was no history of difficulty in deglutition, mastication and speech, fever or malaise, weight loss, insect bite, skin lesion, bleeding tendency or trauma. The family and the past medical history were insignificant. There was no change in the dietary habits of the patient, and she had no adverse habits like tobacco or gutka chewing, smoking, alcohol consumption, and the patient was vegetarian by diet. There was no abnormal menstrual history recorded. Patient was gravida 1, parity 1, and abortion 0. And as of now, I would like to summarize the case. We present before you a 25-year-old female, painful swelling of anterior tongue and the floor of the mouth since 9 years, which was associated with bluish discoloration. It was initially peanut in size and it acquired the present size as shown in the picture. The swelling was not associated with any trauma. There was no difficulty in deglutition, speech or mastication. There was no history of any systemic disease, allergy, hereditary or syndromic condition. And with this much of information, I would like to request the house to come up with some differentials.
It can be a vascular lesion. Patient complains of painful swelling. So it can be a vascular lesion.
Yes, can be a vascular lesion. Anyone else, please?
Can be hemangioma.
Yes, hemangiovascular lesion. Thankful for your responses. On the basis of the history that the patient gave us, we broadly divided our tongue swelling into two categories, painful and painless. Under painful, we grouped trauma, pernicious anemia, chemical burns, allergic exposure, vascular malformation and neoplasia, whereas in the painless swelling, we had ranula, angioedema, anaphylaxis, venous stasis and hemangioma. We also differentiated our swellings into two categories based on the local factors. We had vascular causes and other causes, and systemic factors we presented in the form of syndromic association. The syndrome listed here shows hematoma and vascular malformation of the lung as a secondary manifesting features which may lead to swelling of the tongue as well as bluish discoloration. But these syndromes have some specific peculiar characteristics which mark their hallmark features. Like in blue rubber glove Never syndrome, we can see multiple cutaneous patches and gastrointestinal involvement. While port wine stain are a characteristic feature of Struger-Weber syndrome, whereas Maffucci syndrome shows vascular malformation of appendages in association with enchondromas. No such features, primary features, were evident in our patient, and hence it shows less likely to be of syndromic association, and therefore we rule them out. Moving further to the general examination of our patient, she was well built with a weight of 56 kg. The vitals when examined were within the normal limit. There was no presence of icterus, pallor, cyanosis, lymphadenopathy and edema, and there was no gross abnormality present in the general examination of the patient. For the local examination, we started from the extraoral and there was no abnormality noted. Moving to the intraoral examination, we first started with the hard tissue examination. The patient had normal teeth as per her age. The occlusion was intact. There was no sharpness associated with teeth, and hence we found no positive findings in it. Moving to the intraoral soft tissue examination, on inspection, the labial mucosa, labial vestibule, buccal mucosa, buccal vestibule, and gingiva and palate showed no abnormality, and hence no positive findings were noted. But we found the positive findings on the tongue of the patient. The tip, the mid-dorsal surface, the lateral border of the tongue was involved, as well as the ventral surface and the floor of the mouth showed bluish swelling. On inspection, it was a single oval swelling, approximately measuring up to 5 cm by 5 cm. It was purple in color. The margins were clearly defined and there were no visible pulsations seen. On palpation of the swelling, it was tender, smooth and compressible. It was immobile and there were no fluctuations and pulsation present. This is a pictorial representation of how palpation was carried out in our patient of both dorsal and ventral surfaces. With all these findings and to cut down the R differentials that we then planned for a blind aspiration of the swelling on the OPD basis, and prior to it, we requested for the routine investigation of the patient to check for the blood profile like CBC, prothrombin time, blood glucose, serum electrolytes, LFT, RFT and viral markers. As they were all within the normal range and the viral markers were negative, we then proceeded for the blind aspiration of the swelling. Under all aseptic condition, a 21 gauge needle was used along with a 10 ml syringe which aspirated about 3 ml of frank blood from the tongue. A pictorial representation of how it was done is shown here. With much added information of now for our case, I would again summarize the case to you. And now we present a 25-year-old female, pain and swelling with bluish discoloration of the anterior tongue and the floor of the mouth since 9 months, with no history of systemic diseases or allergy, and frank blood was aspirated from the lesion. I would again request the house.
In today's era of all investigations being available to us, is it a right decision to aspirate a suspected hemangioma or a AV malformation?
So we can aspirate it on the basis.
You can, but should you?
Sir, it is not the main primary diagnostic modality, but To check for it,
You can clinically, I don't think there is any doubt that this is a vascular.
yes, sir.
You just put an ultrasound probe, you will confirm it.
Yes, sir.
So why aspirate?
I mean, you could have landed up with life-threatening bleeding.
Yes, sir.
Bleeding which would require surgery to stop it.
And this was a compressible swelling, so
Yes, sir.
Use the diagnosis to you straight.
Sir.
So the point we are trying to make is that whether on the surface or inside a viscous, you suspect a vascular lesion, preferably you should not put a needle into it.
Sure, sir.
Very good.
And a note for the general surgeons
Yes, sir.
that when you have to palpate the tongue has to be inside the mouth.
Yes, sir.
The moment you protrude and then palpate, the muscles become taut, so we won't be able to palpate properly. So the tongue has to be inside. And
Yes, sir.
Did you palpate for the nodes also?
Yes, sir. So the nodes were not palpable, sir. We checked for the submentis, submandibular, posterior auricular, and the upper jugular lymph nodes, sir. They were not palpable, sir. I would request the House, if with all these findings, can you add something to the differentials that were listed prior? Thank you. Moving forward, the examination and the diagnostic OPD finding revealed no positive association with the other causes that were listed here, and hence we ruled them out. But as the frank blood was aspirated from the swelling, it marks a strong possibility of our lesion to be of a vascular origin, and thus we narrow down our differential diagnosis to vascular malformation, hemangioma, hematoma, and metastasis. To arrive to a much precise provisional diagnosis, we undertook.
Did you do the coagulation profile of the patient? Did I miss that? Coagulation profile was normal, right?
Yes, sir.
BT, CT,
Yes, sir.
PTs were normal.
So as to arrive to a much precise provisional diagnosis, we undertook another diagnostic modality in our OPD itself and palpated swelling using a handheld Doppler, which gave positive audio results for the increased vascular flow in the lesion. This is a pictorial representation of how it was done in the patient, and for the informative basis, we have a video of the audio results that were recorded when palpation was done on the wrist. It's just for an informative purpose. I'm sorry, due to the technical glitch.
Cursor may change.
With all these findings, we then arrived to a provisional diagnosis of vascular malformation of anterior tongue and the floor of the mouth. And to have a much specific confirmatory test and to know the extent of the lesion, we then requested for the angiography of a head and neck, which was suggestive of a slow flow vascular malformation. And to explain its finding, I would like to call Dr. Nija from the Department of the Radiodiagnosis.
Good morning. I am here to present radiological finding of this case. So patient came to us for CT neck angiography, which was done usually for the evaluation of vascular pathologies like malformation, aneurysm, thrombus, and the neoplasm. To do CT angiography, patient lie in supine position in the gantry with both arms next to the body. First of all, we take scout images in AP and lateral view from mid-chest to the vertex. Then we take plain scan, after which IV contrast is injected, which is iohexol, comes under the brand name of Omnimed. Region of interest is kept over the descending aorta, and when it reaches to the 110 Hounsfield unit, that is when the contrast reaches to the descending aorta, scan starts. Due to technical issue, we don't have the access to the scan. We only have the limited pictures that was provided to the patient. So these are CT axial soft tissue windows showing ill-defined hypodense lesion in the right masseter and the right medial and lateral pterygoid muscle.
Can you tell me the strongest skeletal muscle in the body which you are showing here? One of the strongest.
So,
Muscle.
muscle. and a lesion in the anterior and right half of the tongue. In this picture, we can see there's a right masseter muscle is relatively bulkier than the left masseter muscle, and there was also a soft tissue density lesion over the right buccal mucosa. On giving contrast, there was a subtle patchy hyperintensity seen in the arterial phase in these lesions, which gradually increases in venous phase, and it shows the venous pooling and the stasis of the blood in these lesions. These are both lingual arteries, which are normal in caliber and doesn't show any vascular pathologies and the diameter enlargement. There's also a subtle erosion in the inner margin of the right side of the mandible, which can be seen in vascular malformations due to pressure effect and the remodeling. So all these findings were suggestive of vascular malformation, and in fact slow flow malformation. And these are volume rendered images of the CT angiogram with superimposed over the 3D model, which is given to better delineate the anatomy to the clinician. These they show the normal arch of aorta and its branches, and both common carotid arteries and its bifurcation into the external carotid artery and the internal carotid arteries. Both the external carotid arteries and branches of the external carotid arteries were normal in size and show no abnormal dilatation.
Go back, please. What is the artery arising on the right side, the smaller one?
So this is vertebral artery, sir. Both vertebral arteries combine to form basilar artery.
Directly from the brachiocephaly.
Yes, sir. In right.
Is that the normal anatomy?
Yes.
But on the left side?
It arises directly from the arch of aorta. So vascular anomalies can be divided broadly into hemangiomas and vascular malformation. Hemangiomas are very common vascular lesion in the infancy occur due to endothelial cell proliferation, which grows rapidly, and with time because of fatty replacement of the lesion, it goes involute. While vascular malformation can be seen at the birth only, but because it occurs due to abnormal blood and the lymphatic vessel formation, it doesn't involute and grow in size gradually. And it can be divided into slow flow and high flow malformations. Slow flow malformation can be venous, capillary and lymphatic, and high flow malformation like atriovenous malformation and fistula. In imaging, high flow malformation can be seen as a dilated tortuous arteries, which show significant enhancement after giving the contrast. And in case of slow flow malformation, there is no such arteries, dilated arteries, and it gives subtle patchy enhancement in arterial phase and give a gradual increase in enhancement in the subsequent venous phase, which shows the stasis and the pooling of the contrast in the lesion, which can be seen, which was seen in our case, and it was diagnosed as slow flow malformation. So thank you. I would like to request Dr. Hardik to continue the
I
discussion.
have to ask you one question. How many lesions this patient has? Clinically, there is a tongue lesion, and radiologically, you say there is a lesion in the
soft tissue
mastication space.
Soft tissue lesion in the buccal mucosa, sir.
No, but the CT scan corneal cut shows, the
Sir.
X-ray cut shows that the lesion in the mastication space.
Yes, sir.
Where the clinically patient has lesion in the tongue and
Yes,
floor
sir.
of mouth. So
Yes,
are
sir.
there two lesions there in this patient?
Yes, sir. Right side of masticator muscles were bulky in comparison to the left side, and there was a lesion in the floor of mouth and the right side of the tongue.
But the manifestation was only on the tongue and floor
Yes,
of mouth,
sir.
not in the.
Only manifestation was on the tongue. The others were she was asymptomatic.
So this does appear to be producing a soft tissue swelling also. I wonder if this could have been clinically missed. There is a significant swelling and reaching right under the skin. It should have been palpable also.
Sir, actually, clinically nothing was visible and patient did not have any symptoms. We found out that this was the case, but her chief complaint was related to the tongue, and the manifestation was also.
That's okay. Complaint was related to tongue, but was this a finding on inspection?
Inspection, no finding.
Inspection or palpation?
Palpation inspection was received.
And there was no feeding vessel to the tongue lesion?
No, sir.
Couldn't identify on the
No,
inspection?
sir. That's why we called it slow flow malformation.
So the lesion you showed is indeed tongue and the floor of mouth. The muscles, is there a lesion or are they hypertrophic because of increased flow?
So there was a hypodense lesion.
There were lesions. So the same lesion is extending into the muscles also.
You know, they cannot go to that level. That lesion is anatomy.
Actually, we don't have the complete
Scan.
film, so I don't know what it was.
It will not be in a continuity. The lesion will not be continuity of the masticated space here. It cannot be.
They would know.
There are two separate lesions if they are
Not contiguous, there is no.
there are no continuity.
And the other is a very preliminary question which Dr. Hemant was asking. If we suspect a vascular lesion, what is the choice investigation today? Is it contrast CT or is it contrast MRI? Especially when we want to
So
look at
both-
the soft tissues also.
So both are modality of choice. In fact, in case of high
Modality of
creatinine,
choice has to be one. You can say both are equal.
Sir, in
You
case
can't
of
say
high-
both are of choice.
in case of high creatinine, we can go for MRA.
No. Normal renal functions, you have both the options.
So,
As a radiologist, what will give more information?
so CT angiogram.
Sir, because it is a soft tissue lesion, I would prefer an MRI, but we wanted to know if there is any hard tissue involvement, so we advise CT angiogram.
So look for
That's what I also thought, that MRI is probably better for
Would have been better.
soft tissues, and other is that a young female, if you have a choice, you would always prefer MR over.
So to look for any best.
But bone, yes, I agree. The other is, you said that there is no arterialization of any veins. Because if there is an arteriovenous fistula, that means the artery is directly communicating with the vein without a capillary network in between. And those are the conditions where you will have a arterialization of vein, and the lump or swelling, whatever it is likely to be pulsatile. For example, when we create an arteriovenous fistula for a dialysis access, the veins get arterialized. Whereas an arteriovenous malformation runs through the capillary network, and therefore the venous pressure doesn't go up to the arterial level, and it's less likely to be pulsatile.
Thank you, Dr. Neeraj. Good morning, respected Emeritus Chairperson, sir, all senior faculties, teachers, and my colleagues. Before starting with the management, just to recapitulate our case, there is a 25-year-old female with painful swelling and bluish discoloration. Frank blood has been found on aspiration, and angiography suggestive of a low-flow vascular lesion. With no other comorbidities, and all investigations are within the normal range. So, as it's a low-flow lesion with bluish discoloration and is compressible, it is suggestive of a venous malformation. When the lesion is large, total excision is a surgical challenge, and initial surgical intervention can compromise functional as well as the aesthetic outcomes. The philosophy of management then hinges on decompressing the lesion and partial elimination either through laser, sclerotherapy or embolization. The treatment plan we followed is first sclerotherapy. After that, we assess the size of the swelling for 2 weeks. If operable, then we will go for surgery and follow-up. If it is not operable or the size is large or it is not reduced to the extent that we found that it is operable and will give us functional or aesthetic outcome, we again give a session of a sclerotherapy after 2 weeks. So, the sclerotherapy has become the current mainstream treatment for venous malformation. It can be used alone or combined with surgery and or laser therapy. The mechanism of action of any sclerosant is destroying the blood vessel's endothelial cell, acceleration of protein coagulation, formation of thrombosis, platelet adhesion. That subsequently occludes the blood vessel and cause shrinkage of the lesion and decrease the vascularity as well. The sclerotherapeutic agents commonly used for venous malformation are absolute ethanol, sodium tetradecyl sulfate, and bleomycin. In our case, we have used bleomycin as sclerosant that recently shown effective treatment for venous malformation via intralesional injection. It is a cytotoxic antineoplastic drug that was discovered by Umezawa, first used by Ura. It acts by inhibiting DNA synthesis and damages endothelial cell by non-specific inflammatory reaction. That's why it causes granulation tissue and the formation of fibrosis that occludes the blood vessel and cause shrinkage of the lesion. So, certain cross-consultation are required for the local administration of bleomycin. First is the chest and TB reference to check out if the patient has any pulmonary insufficiency obstetric and gynecology reference was done as she was a young fertile female, and pediatric reference was done as she was having a 11-month child, but the child was able to bottle feed, so strict no for the breastfeeding was told to the patient. So, first, informed consent was taken for intralesional bleomycin injection. Bleomycin 15 mg diluted in 5 ml of normal saline mixed with lignocaine was prepared. Complete aspiration of the intralesional fluid was done with a 21 gauge 10 ml syringe. The bleomycin was multiply injected and patient was remained under observation for approximately 1 hour. So the vitals were monitored. We also looked for necrosis, logging erythema at the local site. There was regular follow-up of the patient within 3 to 4 days to check for any local site complication. So observation for 2 weeks for optimal action was bleomycin was checked, but reduction in size after the first session was not significant, that it was operable. So among us we discussed to give total of 3 cycles of bleomycin sclerotherapy. So this is the residual lesion approximately 1 to 1.5 centimeter at the tip of the tongue that had to be removed to avoid reoccurrence. The lesion size was reduced to more than 50% of the original size in 45 days. Before starting with the resection, we go for the ligation of unilateral lingual artery to prevent hemorrhage during the resection of the tip of the tongue, and as it is supplied by the deep lingual artery. So this is the resected part measuring around 1.5 to 2 centimeter or less than 1/3 of the tongue was resected and primary closure was done. The resected part was sent for histopathological examination. Now my colleague Dr. Amit Kumar from the Department of Pathology will tell us about the histopathology of the case.
Since this was a vascular lesion, you need to tell us how much bleeding was encountered, how much was the blood loss, was any transfusion required?
No, sir, no transfusion was, I have not told, sir, sorry, sir. No transfusion was required, sir. We ligated the lingual artery because according to one article, Suzanne et al., it clearly told that unilateral ligation of lingual artery will allow, stop significant blood towards the tip of the tongue. So during sir incision, there was no large amount of blood loss, so that we have to transfuse the blood, sir. Even we have taken the pre and post HB, they were above 10, sir.
This is very good process. In hysterectomy also sometimes when the PPH is there, due to internal ligation, it stops the bleeding.
But the lesion was crossing. The lesion was crossing midline.
Yes, sir.
So must be getting blood supply from the other lingual artery also.
Yes, sir, but it was more dominant over the right side, so we did right side unilateral lingual artery ligation because our more resection part was towards the right side, sir.
What suture do you use for?
Sir, Vicryl, sir. We use Vicryl, sir, round body, sir. In both the layers. Yes, round body needle, sir.
What size?
Sir, 30 or sir, 40, sir.
So all surgical students, when you are asked what suture, in the first go itself you have to tell the
Yes,
needle, the size,
Yes.
and what kind of suture.
Yes. Thank you.
Cutting edge can you use cutting edge?
Sir, because as it can tear, sir. If the cutting edge, we can use a reverse cutting needle instead of that, sir. Because when we pass the suture, it can lead to tear of the edge, sir. So the reverse cutting would be better for a round body, sir.
Good morning, respected sir, all faculty members and my colleagues. Now we'll talk about histopathological part. First, gloss examination. We received excisional glossectomy specimen which was measuring 2.5 into 2 into 1 centimeter, and the cut surface of the specimen was predominantly hemorrhagic with focal creamy areas. Now we'll talk about microscopic features. We see a squamous epithelium lined tissue showing a vascular lesion comprised of abundant large, widely dilated vascular channels of irregular shape and size, which are haphazardly arranged in the submucosal connective tissue stroma, which are lined by flat endothelial cells, and the smooth muscle layer is absent in most of the channels. The lumens of the blood vessels are filled with blood and supported by fibrostroma. Areas of hemorrhage in the stroma are seen. Focal thrombosis is seen, and mild inflammation also seen. There is no evidence of endothelial hyperplasia and no evidence of malignancy in the overlying squamous epithelium. This is low power image showing vascular channels and interlunar thrombus. This is a high power image showing thin walled blood vessels and with inconspicuous endothelial cells with flat or round nuclei. The smooth muscle layer is absent in this image, but in another image we see a thin smooth muscle layer, and there is presence of non-atypical endothelial cells lining the inner aspect of the vessels. As the radiological diagnosis was a slow flow malformation, so we had three differentials: venous malformation, capillary malformation, and lymphatic malformation. In capillary malformation, there is proliferation of capillary type blood vessels of rounded appearance, and in this was not so in our case. And in lymphatic malformation, there is presence of proteinaceous eosinophilic substance in the lumen of vessels and absence of RBCs. So this also it was also not in our case. So our diagnosis is venous malformation. Now I would like to call Dr. Hardik for further discussion.
My request to pathology colleagues, in future, whenever you want to show us an abnormality, in the low power view, always give a comparative normal, so that we can quickly appreciate what is normal and what is abnormal.
Thank you, Dr. Amit. Now the patient was discharged on the third post-op day, and regular follow-up was done at 1 week, 2 week, 1 month, 3 months, 6 months, 9 months, and 1 year. So this is the 6-month post-operative and 1 year post-operative picture of the patient, and we can clearly appreciate that there is no swelling, there is no bluish discoloration, the aesthetics are maintained. And the patient has excellent results.
What do you mean by aesthetics are mentioned?
Sir, we did sclerotherapy just so that we do not lose large amount of tissue, as tongue has taste buds, sir, and the shape.
So tell me the sensory nerve supply of anterior two-third of tongue.
Sir, sensory nerve supply of anterior two-third of the tongue is, sir, lingual nerve supply for general sensation and chorda tympani supply for the taste. Just the circumvallate papilla are supplied by the glossopharyngeal nerve, sir, for both general sensation and as well as taste, sir.
What happened? So tell me the total nerve supply. How many
Yes,
nerves,
sir.
cranial nerves are there for supplying the
Yes, sir. Sir,
motor as well as sensory?
yes. So the tongue is
Third
divided.
and third ear, no?
Yes, sir. So the tongue is divided into 3 parts, sir: anterior 2/3, posterior 1/3, and posterior most part, sir. So the anterior 2/3, the motor supply is hypoglossal nerve, except the palatoglossus that is supplied by the cranial root of accessory nerve to pharyngeal plexus, sir. And sir, the posterior 1/3 is supplied by the glossopharyngeal nerve, both for the general sensation and motor, and the posterior most is supplied by the internal laryngeal nerve, a branch of vagus nerve, sir.
Tell me the arterial supply.
Sir, arterial supply, it is supplied by lingual artery, sir. So the anterior 2/3
Branch
is.
of which?
So it is a branch of external carotid artery. It is the anterior branch of the external carotid artery, arising just opposite to the tip of the greater corner of hyoid bone, sir.
Tell me lymphatic drainage.
So lymphatic drainage, sir, the tip of the tongue is drained by the submental lymph node, the center part by submandibular and deep cervical. Sir, the jugulo-omohyoid are called the lymph node of the tongue. All these drain into the, sir, jugulo-omohyoid.
Finally, they drain into deep cervical lymph node. All?
Yes, no, sir,
Retrospectively thinking, if we had given some more sessions of sclerotherapy, could surgery have been avoided? Because the response was quite good.
Sir, in this case, if this patient would have come to us earlier, if the size of the lesion was less, then we would have only treated him by sclerotherapy and without any requirement of surgery.
So is there a limit on the number of sessions or volume of sclerosant?
Sir, people have given up to 12 sessions also. The literature says that. But sir, in this case, because tongue is a mobile structure and the fear of recurrence was there, and she can get injury from anything like a sharp cusp or while chewing the food, so there can be extensive hemorrhage. So we went for surgery.
And radiologist, was there any role of embolization?
Sir, embolization I would go for only in high flow lesions.
So what happened to the masseter lesion? Did you do a diagnostic work? We've kind of forgotten.
Sir, after we treated it for the tongue, we only did sclerotherapy for in the RMT region, retromandibular trigon region, that was involving the masseter.
There was another venous malformation also.
Yes, sir. We suspected it on the basis of the CT only, and we only give sclerotherapy, but the patient was asymptomatic regarding to that.
This patient is 25 years old and symptoms of for 9 months is duration, as you told us. And this is, I believe, a congenital lesion. So how come it is manifested at this age? Why did it enlarge at this stage of life?
Sir, because it's a vascular malformation and not a hemangioma. Hemangiomas usually grow up to 6 to 8 months and then they slowly evolve by 5 to 9 years. It's a vascular malformation. It is not diagnosed until the second decade of life.
Obviously, it was not there. It is at such a conspicuous place and would not have been overlooked.
It was the size.
For some reason, in the last 9 months, it has increased in size and has become manifest.
Sir, might be due to what I think is due to hormonal fluctuation, because she was a pregnant.
These lesions are under hormone influence. So you said that she had an 11-month-old child who probably was lactating. So probably the pregnancy and lactation played some role in making the lesion manifest.
Yes, sir. It's
Puberty. That's why puberty also comes up. Yes.
Thank you. Now I would like to call Dr. Ruchika Tiwari, ma'am, professor and my guide from the Department of Oral Maxillofacial Surgery, for the discussion part. Thank you.
A very good morning to the August gathering. Respected Emeritus Chairperson Dr. M.S. Pankar sir, Dr. G.N. Saxena sir, Dr. Malhotra sir, Dr. V.K. Kapoor sir, and Dr. Sachdeva sir. As Dr. Hardik has already discussed the treatment plan and management, I will be going ahead with the discussion. So the overall incidence of vascular malformation in the general population is around 1.5%, and 2/3 of them are the venous malformations, and 40% of them occur in the head and neck region. And the various factors stimulating the growth of these malformations are the trauma, infection, and hormonal fluctuations, like we saw in our case, which occurs in pregnancy and puberty. So according to the International Society of Study of Vascular Anomalies 2014 guidelines, they divided the vascular anomalies into vascular tumors and vascular malformations. Vascular tumors are further classified as benign, borderline, and malignant, and malformations into simple, combined malformations of major named vessels and associated with other anomalies. So our case was a simple vascular malformation, in that it was a venous malformation. Hemangiomas and vascular malformations are not synonyms, and these are the basic differences. A hemangioma is present at birth, mostly diagnosed by 1 year, whereas a vascular malformation is present at birth but often not diagnosed until the second decade of life. There is a rapid growth in the hemangioma until age 6 to 8 months, and then it slows and involutes by 5 to 9 years. There is slow growth in a vascular malformation throughout life, with increase in response to infection, trauma, and hormonal fluctuations. Hemangiomas have a neoplastic growth with increased endothelial cell turnover, whereas the growth in vascular malformation is due to flow dynamics by recruitment of the collateral blood supply. Osseous involvement is rare in hemangioma, whereas it is 35% in the vascular malformations. And female to male ratio is 5:1 in hemangioma, and in vascular malformations it is 2:1. A hemangioma is usually low flow, whereas a vascular malformation can be high flow like arterial or arteriovenous, or low flow like capillary, lymphatic, and venous. Hemangiomas usually do not require treatment, whereas a vascular malformation often requires treatment. So Dr. Sanjeev S. Nair, who is a pioneer in head and neck vascular malformations from South India, and he's also published book and many articles, and I was very lucky that he was one of my mentors. He gave this practical classification which helps the surgeon in surgical planning and to delineate a surgical approach for that particular lesion and reconstruction for that vascular lesion. So type 1 are mucosal or cutaneous. They're superficial lesions. They require complete excision, and a lot of local and regional flaps are available for their reconstruction. The type 2 are the submucosal and subcutaneous. They require elevation of flaps and the removal of the lesion. Type 3 are the glandular ones. They are the lymphovenous or the venous malformations of the head and neck, which require the removal of the gland along with the lesion. Type 4 are the intraosseous ones, which require removal of the bone and then reconstruction. Type 5 are the deep visceral ones, and they're the most difficult to treat, like occurring in the parapharyngeal region or the infratemporal fossa region, and they might require skeletal access osteotomies for their complete exposure and removal. So the diagnosis of superficial venous lesions is by direct clinical examination, whereas for deep-seated lesions, we require further investigations like ultrasonography, CT, MRI, angiography. These are the clinical findings of a venous malformation. A venous malformation will be bluish purple in appearance. Occasional palpable phleboliths will be there. Phleboliths are the calcification in a venous malformation, and they occur because of stasis and inflammation. They will be soft and compressible. Swelling will be there. Pain will be there. They will be well defined or diffuse, and they can be superficial or deep. They will not have hyperemia, pulsations, and palpable local thrill, which are found in arteriovenous or arterial malformations. So this is the approach we followed. First we took the history and examination, and then we came to the conclusion that it is a vascular malformation, and then we categorized it into a low flow lesion. So the treatment options we had were excision, laser therapy, plus minus sclerotherapy. So the take home message I would like to give is the venous malformations are common in maxillofacial region, and early diagnosis is very important. The treatment can be simpler. This patient, if he would have come to us earlier, we could have treated this patient only by sclerotherapy, avoiding surgery. And also there can be social implications or marital issues if the patient is disfigured. Also there can be morbidity due to trauma, because tongue is a mobile structure, and any injury to that vascular lesion by either a denture or a sharp tooth can lead to extensive hemorrhage, and patient might need hospitalization. So the treatment spectrum varies from observation to surgical resection and reconstruction. We can either go only for sclerotherapy or sclerotherapy with surgery, or if the lesion is big, we have to go for reconstruction. And utmost importance has to be given to differentiate whether it's a high flow lesion or a low flow lesion, because the treatment will vary. For example, the sclerotherapy is mainly indicated for low flow venous malformations. For arterial malformations or arteriovenous malformations, we have to first go for embolization. So in our case, we did a methodological approach that first we aspirated the lesion in the OPD itself, and then we categorized it into a low flow venous malformation, and then we went for sclerotherapy. With each session of sclerotherapy, the lesion reduced in size, but it did not completely resolve. So we took the decision to go for surgery, and one good thing we did is we did not go for upfront surgery, because if we would have gone for upfront surgery, then the surgical resection would have been very extensive. So we have treated our patient well with successful outcome and without any functional compromise, and for that I would like to thank Dr. Amit Kumar sir, the Mahatma Gandhi Hospital, for its excellent infrastructure and facilities.
मेरी जीव में पहले सूजन और दर्द रहता था। मैंने महात्मा गांधी हॉस्पिटल में मैक्सिलोफेशियल सर्जरी विभाग को दिखाया। उन्होंने मेरा इलाज किया। इलाज करने के बाद अब मैं ठीक हूँ। मुझे खाने पीने में और बोलने में कोई तकलीफ नहीं है। मैं बहुत संतुष्ट हूँ। मैं महात्मा गांधी हॉस्पिटल की सुविधाओं और उनके डॉक्टरों को धन्यवाद देना चाहती हूँ।
The idea to show this video is that patient does not have any functional deficit. She is able to speak well and she is able to eat her food well. This is another case of AV malformation of the anterior chin region, and we did CT angiography, and it was shown that the feeding vessels were bilateral facial arteries. So first we went for ligation of the facial arteries, and then we treated this case with sclerotherapy with successful outcomes.
Why not embolization?
Sir, it was not a high flow lesion. So I would like to thank Honorable Emeritus Chairperson Sir for his constant support, guidance and motivation. Mahatma Gandhi University of Medical Science and Technology, Dean and Principal Mahatma Gandhi Dental College, Dr. Narendra Padiyar Sir, CCR Review Committee, especially Dr. Lalit Mohan Sir, Manish Kakkar Sir, GN Saxena Sir and Raman Sir for their constant improvements in our presentation, and the distinguished faculty members and students, Department of Radiology, Pathology and patient and our family members. Now I would like to call Dr. Nahata Sir for informing us about an upcoming event.
एक second. First of all, I want to congratulate you. And especially your President Hardik